Hello and welcome to another episode of Cracking Addiction with Philippe Naren and Fergal Armstrong. In the episode of Cracking Addiction today, we're going to be talking about nitrous oxide, or NANGs as it's colloquially known on the streets. So nitrous oxide falls under the classification of inhalants, and it's quite popular amongst the adolescent age group. And in fact, Fergal, when I was preparing for this episode, I came across a 2020 survey from the UK, and this was from England and Wales, and it found that amongst 16 to 24-year-olds, 9% had tried nitrous oxide in the year prior, which is second only to cannabis amongst recreational drugs. I wasn't aware it was so popular or had such widespread availability. Are you surprised by results like that?
No, I'm not. I mean, when you consider that originally it was invented as laughing gas, and they used to have laughing gas parties. They used to have social gatherings in the Victorian era. Everyone come around to someone's house and inhale the nitrous oxide and start rolling around laughing. So it's an inhalant. It's a euphorogenic inhalant, and unfortunately, not a lot of people know this, and I suppose this is why we're talking. It is also associated with harm. But I suppose really it's important, before we go into the harms of nitrous oxide, we need to understand what it is medically. So it's nitrous oxide. Yes, it was described as laughing gas, but actually it's a gaseous anesthetic agent. So you can actually contribute to anesthesia by using nitrous oxide. And it also gives you a sense of relaxation. And it does this because it is an NMDA receptor antagonist. And as we know, NMDA receptors, they're one of the receptors for the glutamate, the main excitatory neurotransmitter in the brain. So effectively it blocks rapid glutaminergic signaling, and therefore it contributes to sedation. And that's how it has its medical use. And it's still used medically in anesthesiology or anesthesia. I mean, I remember when I was training in the anesthetic department in North Wales, I used to give nitrous oxide as part of my anesthetic regime. That was many years ago.
And I guess that ready availability is one thing, but I guess also the speed of onset is the other one, Fergal, because essentially, as you mentioned, these are inhalant. This is an inhalant drug, and once it's inhaled and it crosses the pulmonary bed, the onset of effect is really a few seconds. It can take onset within 15 to 30 seconds. Admittedly, the duration of effect is around, I think, 15 to 30 minutes or so. But usually, people are using multiple cartridges, canisters, and the effects do pile up. But that speed of onset is quite interesting, isn't it?
Yeah, it's one of the reasons why it is misused. But I think we need to go back to the availability to find out why it's available. So it's used in anesthesia. Dentists used to use it a lot, but it's also freely available, and is not restricted, at least not in Australia. It's freely available as canisters, whose purpose is to actually inflate balloons, and also it's also supposed to whip up cream as well, isn't it?
Indeed, it is.
Yeah, so you can get it. You can buy bucket loads of this stuff perfectly legally. It's not controlled. It's not a controlled substance at all.
And I guess the mechanism of using these canisters is also interesting in that they have to be cracked, and usually the gas is then taken in by the body. Some people use balloons at the end to kind of get the gas and then inhale from the balloon. I have seen people try and inhale directly from the canister as well, and that's caused a few issues as well that I've seen, which we'll talk about later. But it is a bit arduous in terms of extracting the gas from the product source, isn't it?
Yeah, they say there's about 8 grams of gas in every canister, and 8 grams of any gas is not that much. So you got to use. I mean, people are using NANGs who are misusing NANGs for the clinical effect. They can use 50 to 100 NANGs a day. And that just speaks to the dedication they have in trying to achieve some form of euphoria with this drug.
Indeed.
Yeah.
Now, you've mentioned the euphoric effects and also the fact that it does cause sedation as well. That combination is quite interesting, isn't it, in terms of the reinforcing kind of qualities of nitrous oxide, and how sometimes it can be hard to wean people off nitrous, in the sense that I've seen a lot of predominantly adolescents who've used a lot of nitrous, and we'll talk about the harms and the systemic effects of prolonged exposure to nitrous oxide. But trying to get people to wean or stop their nitrous use, even with evidence of harm, I find quite difficult. And I think it's that euphorogenic effect, but also the sedative properties that make it really a hard drug for patients to seize. Has that been your experience as well?
Yeah, I mean, you've just touched on one of the definitions of addiction, isn't it? Where, you continue persistent use despite harms. I mean, that's one of the DSM-5 criteria. But yeah, it is true that, nitrous is one of those substances that people do continue to use. And that speaks to the purpose that drugs serve in someone's life. I mean, no one woke up in the middle of the night as a small child excitedly thinking to themselves, when I grow up, I'm going to become a substance use dependent person. I'm going to use drugs. We all as human beings, we all have pain. We all suffer in life. And so the problem is that some people find ways of coping with that pain that is maladaptive and that causes harm. And so, unless you address the underlying reasons for drug use, you're never really going to actually minimize the drug use itself. Lecturing teenagers on, you shouldn't do drugs because it's harmful for you, that just doesn't work. So, why do they use the drugs? Are they bored? Are they in pain? Are they anxious? What's going on? And how do you then treat the underlying causes of that drug use? And that's a much more difficult question. But unless you identify the answers to that question, you are going to continually meet and confront persistent drug use in this cohort.
And I guess throughout this episode thus far, we've hinted at some of the harms associated with nitrous oxide. And I guess we might as well run through them and go through some of the organ systems that are affected by nitrous oxide. And I guess we'll start off with the neurological system. And the main side effect that we know of with nitrous oxide is its effect on B12 and how it inactivates B12 and the harms associated with that. But I think we'll take a step back, Fergal, and I might ask you a bit about B12 pathophysiology and how nitrous oxide turns active B12 into inactive B12, and I guess going through the importance of B12 for DNA synthesis and the subsequent effects on the system.
Right. So very briefly and very simply, nitrous oxide oxidizes cobalt in vitamin B12 from the 1 plus to the 2 plus. And that therefore renders it inactive. And there are two forms of active nitrous oxide. One is adenosine cobalamin and the other one is methyl cobalamin. And unless you have active adenosine and methyl cobalamin, you don't actually have the active vitamin B12. And these substances are very important in the function of key enzymes in a whole biochemical pathway. So, for instance, adenosine cobalamin is vital for the function of methylmalonic coenzyme A mutase, MM-CoA-M. And methyl cobalamin is actually very important for the function of methionine synthase. And if we go to methionine synthase, the bottom line is methionine synthase does what it says in the tin. It produces methionine, and methionine is a key amino acid for the production of myelin. And without myelin, you have nerve and brain degeneration. You also have some upstream accumulation of precursor products, which then allows us to, and we'll talk about the identification of deficiency syndromes and the use of precursor products to identify deficiency in a moment. But suffice it to say, if you've got no methionine synthase, you've got no methionine, you've got the inability to form myelin, which is bad for the brain and bad for the nerves. Then on the other hand, if you've got hypo-functioning adenosine cobalamin, then you are unable to convert methyl tetrahydrofolic to tetrahydrofolic acid. And tetrahydrofolic acid is the key product that allows you to produce DNA. It's one of the key products that allows you to produce DNA. So another downstream problem is you've got the inability to produce DNA. So the bottom line is NANGs, B12, nitrous oxide, knackers B12, which then does two things. It stops you producing methionine. It stops you producing tetrahydrofolic acid.
Mm-hmm.
So what are the effects of that? So if you've got no methionine, you've got no myelination. If you've got no myelination, what does that happen? Well, that causes subacute combined degeneration of the cord, which is a neurological degenerative disorder associated with the loss of balance, loss of reflexes, and spinal cord pain. And if you've got no tetrahydrofolic acid, then that causes a megaloblastic anemia. So effectively, you've got neurological disease and you've got hematological disease, which are the main manifestations of NANG misuse, secondary to inactivation of B12.
That's fascinating, Fergal. And I think the thing also to take away from this is that nitrous oxide use and chronic nitrous oxide use causes a functional B12 deficiency. So you can actually have on a blood test a normal B12 level that does not show the active B12 that is which is the marker of that DNA synthesis. So you can have the functional B12 deficiency with a normal pathology test. So I guess my question to you, Fergal, is I've seen some clinicians do tests for MMA levels or homocysteine levels. Do you do any fancy tests at all, or check for active B12 for some of your patients with nitrous oxide?
Well, I think we need to explain what those blood tests are. So I think really it's important to understand that MMA is methylmalonic acid and homocysteine is homocysteine. And these are precursor products that are elevated. So we know that homocysteine is elevated in both in the presence of B12 deficiency and also in folic acid deficiency. And we know that MMA, methylmalonic acid, is elevated in the presence of B12 deficiency on its own. So that gives you some kind of ability to work out relative deficiency states. The other thing is it's important, I just want to emphasize the point that you've introduced, that the functional deficiency does not show up on blood tests. And really, we know actually that nitrous oxide misuse actually causes a spurious elevation of B12. And that there's also the corollary where you get a spurious reduction in B12 levels without functional deficit, and such drugs like Dilantin and also the combined oral contraceptive pill, these will actually lower your B12 levels. So the question then is, how do you actually diagnose proper B12 deficiency? Well, moving away from the presence of nitrous oxide, if you really want to be sure about a B12 deficiency, yes, it's nice to have a low B12. But really, you cannot really diagnose it unless you've got an elevated MMA, and also having an elevated homocysteine gives you that additional information. In the context, however, of nitrous oxide use, I don't think that those enzymes or those blood tests add any value, because it causes a functional deficit. So if you suspect B12 deficiency due to nitrous oxide use, you are going to get normal blood levels of B12. I suppose functionally it can cause a rise in MMA, but I think it's more important to actually identify the use of nitrous oxide in the clinical picture, stop the nitrous oxide, and then flood the system. It's my usual practice basically to flood the system with B12. And then the thing is, here's a question for you. Even though you know that nitrous oxide causes a dysfunction of B12 and there really isn't actually a deficiency of the molecule, do you actually treat NANG misuse or subacute combined degeneration of the cord with B12 injections in the context of nitrous oxide? I mean, I do, but I'd be interested in your thinking on that.
As far as I'm aware, there's no real evidence in this sphere.
Yes.
The cases that I've seen, we have treated, especially if there's neurology, we treat.
Yeah.
Sometimes, and I think this is one of the interesting things. Sometimes the neurology that we see does resolve once the nitrous oxide use is ceased and B12 is replaced. However, that's not a guarantee. So even if there is neurology as a result of nitrous oxide use, so say someone's got a polyneuropathy or something along those lines, unfortunately, sometimes the damage can be permanent despite abstinence from nitrous oxide and B12 supplementation and even parenteral B12 supplementation. Sometimes there can be improvement, but there's no guarantee, unfortunately. So we do treat for what it's worth, just because the harms of using the treatment are minimal. But I think we're doing that without a robust evidence base. And I'm thinking you're somewhat similar, right, Fergal?
Yeah, if I have a good going case of subacute combined degeneration of the cord secondary to nitrous oxide use, I will advocate abstinence, and then I will give parenteral B12 every second or third day for a couple of weeks until there's no further improvement in symptoms, even though theoretically abstinence itself is enough to stop that. But you just want to cover all bases. The other interesting point is that there's two interesting points. First of all, there are certain clinical guidelines that advocate the use of the supplementation with methionine, because functionally, the reason why functional B12 deficiency causes subacute combined degeneration of the cord is because it causes a methionine deficiency. So I always advocate that we replace with methionine, which is an amino acid. And then the other issue is, do you actually supplement with tetrahydrofolic acid? Because you can actually give synthetic folic acid, i.e. tetrahydrofolic acid, in tablet form that actually bypasses that metabolic enzyme step that is B12 dependent. So you can actually replace that. So if I have any hint of any anemic problems or any rise in the MCV, then I will also do that. I mean, that's another interesting point. I mean, to what extent do you use an MCV to diagnose functional or even actual B12 deficiency?
It's one of those things, as you mentioned, megaloblastic anemia is a sign of B12 deficiency. It kind of just adds one of those tools to our armamentarium. It's not pathological, as in there are a lot of things that can cause a raised MCV. There are a lot of differentials there. But in this clinical setting, it's, again, one of those markers where we could suspect it.
I mean, the interesting thing about a raised MCV is, yes, it's a marker of B12 deficiency. It's also a marker of alcohol, thyroid disease, and myelodysplasia. So you can actually have someone who's misusing alcohol and also misusing NANGs coming up with a raised MCV. And you've actually got to be aware of that entire range of differentials. So we've talked about, megaloblastic anemia and subacute combined degeneration of the cord. And we've used these terms. Philippe, do you want to explain what megaloblastic anemia is?
So anemia is essentially when you have less or decreased red blood cells. And megaloblastic anemia is when those red cells are larger than they're normally meant to be. So there are three types of anemia. There's microcytic, when the red cells are smaller than they're meant to be. Normocytic, when they're the same size as they normally are. And macrocytic, so when the red cells are larger than they are. And the reason we have these classifications is different disease processes can cause different types of anemia. And when someone has a particular type of anemia, we can try and identify the cause of it and treat it appropriately. Yeah.
And what is subacute combined degeneration of the cord, and how does that present?
So subacute combined degeneration of the cord is, we were talking a bit about myelin, which is nerve linings, and how they are affected by B12 deficiency. So subacute combined degeneration of the cord is a degeneration of the dorsal and lateral columns of the spinal cord due to those myelin sheaths getting demyelinated or not having as much fat in them or around them as they normally have. So it's a disease where you get decreased sensation, decreased functioning, and it's worsening paralysis over time. So it is a quite significant pathology.
And it does cause central neuropathic pain as well. I mean, I think it's really important to emphasize that it's not a painless condition.
No, it is.
It does cause pain. So it causes pain, sensory disturbance, and motor disturbance. Yeah. So, and all from laughing gas at the end of the day.
Yeah. And I guess that's one of the big take-home messages here as well, because this is a readily available product. You can get this from stores. There's no real restriction on buying it, and children can buy it pretty easily. There's no real age restriction on obtaining it. So it's something that is omnipresent in many respects. You don't have to go searching very hard to find it. And as I mentioned at the start of this presentation, it is one of those drugs that is quite ubiquitous in its usage amongst adolescents, and in particular young adolescents, with potentially dire consequences. Would you agree with that, Fergus?
Absolutely. It's not just also the organ dysfunction due to B12 inactivation. When you're cracking open these nangs and inhaling them directly, you can get third-degree cold burns. I've had patients who need plastic surgery repairs to various parts of their face.
Not only that, though, it's a pressurized gas, so there's always the risk of barotrauma and pneumothoraces and that kind of stuff. It is one of those things that can cause quite significant injuries just by route of administration as well. And those pressurized gases, it's quite dangerous.
Absolutely.
So I guess in the episode of Cracking Addiction today, we've had a wide-ranging discussion on nitrous oxide or NANGs. We've talked about how NANGs work, the pathophysiology of the B12 deficiency associated with nitrous oxide use, and also the different organ systems affected. So thank you again for your attention and company on this episode of Cracking Addiction. Please remember to like and subscribe to both the YouTube channel and the podcast. So thanks again for your company, and bye for now.